أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم. Now today onwards I want to discuss some of the X-rays as a part of the clinical profile, as per clinical profile, as it was presented to me. This is my experience which I am talking about. People do have the access with them, because X-ray chest PA view is one of the routine investigation we advise to the patient. First one is the blood CBC, which inshallah I will tell you next afterwards how to interpret it, and going from the random blood sugar, adding in it urine DR, and then plain X-ray chest PA view. Every case which is presented in OPD should have done these investigations. Whether the case of dermatologist or surgery, or the case of gastroenterology, or it is the case of nephrology, whatever it is, don't mind it. Every specialty do these tests before going forwards. So today I want to present one of this in front of you. And now starting with this one. Bismillah ar-Rahman ar-Rahim, Alhamdulillahi Rabbil Alameen. I think you will enjoy these reporting by me. I am Professor Syed Ali. I am a visiting professor of medicine and is a part of the team of the PDC, Jinnah Sindh Medical University, Karachi. So how I will take this one? Clinical chest radiology, reporting plain X-ray chest. 9 sessions I have taken. 9 sessions in radiology. So a half-hour workshop or 1 hour workshop of the plain radiology chest mean nothing, because people will like these type of workshop, but actually they cannot do in their practice. They often dependent on the reporting by the radiologist. You have seen the case, you have advised the X-ray chest, so you have to report it. It is better because you have seen that patient. Now the first case which I want to present has come to me because of he want to do surgery for the diabetes mellitus, what is called as the diabetic foot, and the anterior surface of the right foot, means distal 1/3 of the foot, along with the fingers, they become gangrenous because of the vascular pathology associated with it. And gangrene here, it was a dry type of gangrene. If you leave this gangrene as such and try to save it, often it will become infected. It will lead to the spread of the infection as septicemia and then pyemia. And patient will end up in the septicemic shock. So you have to remove this part because it is now become gangrenous. It is the ischemic necrosis followed by the total loss of the function. If it's totally lost, you have to remove it. The X-ray was given to me. Now, before this, the CBC was given as hemoglobin was 12 gram, and the total leukocyte count in this patient was 15,500, means the infection is going on. Neutrophil was about 80%, 82%. Absolute count of the neutrophil was increased, And there are evidence of thrombocytosis in this patient. It was about 480,000, and it is acute phase reactant, you know that. And the ESR is 74 millimeter per first hour. It means that acute phase reactants are increased along with this. The first investigation. The second investigation, random blood sugar was 222. And hemoglobin, last time he has done A1C, was 9.4. Now he had taken the oral hypoglycemic and then followed by the injectables, insulins. And the sugar was not controlled up to the mark. The third routine investigation was urine RV. Before I proceed onwards, urine RV, the specific gravity was 1.032, means that it is a high specific gravity urine. Because proteinuria, glycosuria is present in this patient, very marked proteinuria, the nephropathy is going on. There is evidence of the nitrite positive. Evidence of WBC was 8 to 10, that he has got the infective process in the urinary tract, and some of the crystals of the uric acid are present. It means that he has got probably uric acid levels are higher, hyperuricemia. Probably he is the patient of metabolic syndrome, we don't know. Because the fourth investigation was routine was Xray chest. Now this is his Xray chest. Now Xray chest were reported like this. The requirements of these patients is this: it should be PA view. PA view, why it is PA view? Because the spine is not markedly visible and intercostal intervertebral spaces are not visible. It should be clear if it is. Now this is the spine which is going on like this. So he has got scoliosis, and this is a very interesting finding in this patient. Because of the scoliosis, he cannot. He stood in a straight line. It's difficult because it is moving like this. The spinous processes are visible here. Shows the scoliosis. Scoliosis means lateral view is needed for kyphoscoliosis. So reason behind it, what is the reason? There are many reasons behind it. He tried to be in a straight line because two spinous processes, one is this, one is this. Make a point 1, point 2. Now make a line here. It is like this. The patient is tilted on the right side. Now one line is drawn here, should be 90-degree angle, no. He is not straight, he is standing. Why he is standing? Because first rib, second rib, third rib, fourth rib, fifth rib, sixth rib, seventh. In the seventh it is dome of the diaphragm. If it is at the other view, AP view or etc., or he is in a sitting position, then this dome will actually go higher here. It is actually in the position of standing. PA view, this is frontal projection. And what happens next is he has taken the breath deeply and hold the breath properly. It means that the bronchovascular markings are visible very clearly. They are not admixed. There is no haziness here. You can differentiate between the aerograms and the ray lines, the bronchovascular lines, markings. It means that he is in a still position, S plus S plus S. The quality of the film is good. These artifacts are there. And then the second part is the bony skeleton. Let's look, the clavicles is normal. The rib cage, first, second, third, first intercostal space, second, third, fourth, fifth, sixth, first rib, second rib, upper border, lower border, upper border, lower border, they are equal in respiration, and they should be, the intercostal space should be at 2.5 centimeter. If it is less than 2 centimeter, it means that they are narrow spaces. If they are more than 2.5 centimeter, means dilated, expanded spaces. You see in COPD, and if it is less than that 2.5 or 2, it means that possibility of the interstitial lung disease, fibrotic disease of the lung. The spaces are normal. This is the scapulae posteriorly, and this is the lateral margin is outside. It should not be inside. The spine. So this is the cervical spine there above, and then the thoracic spine is not in one line. It's moving like this. I already said it is in kyphoscoliotic position. Scoliosis is clearly visible in this patient. These are the bony skeleton. It's summary of it, I would say. Soft tissue shadows around it, here, in the middle part, in the upper neck, side of the neck, normal. There is nothing abnormality is visible in this X-ray. So soft tissue shadows are normal. Trachea is slightly deviated towards the left side because it should be neglected because of the positioning of the patient. You cannot comment it. Trachea ends at the sternal angle. This is the one. Here the trachea divided into two, right principal bronchus and the left principal bronchus. The angle between the two is called carina. A carina is usually 120 degree, which is seen here. It should be 120 degree. And then afterwards, the trachea definitely is not central. I say it is slightly towards the left side because of the bony deformity, spinal deformity. The next point you see is the lungs. Lung areas are divided into second rib, you make a line, imaginary line, and the fourth rib, you make a straight line there. There are 6 areas or zones, right upper, right middle, right lower. The left upper, left middle, left lower. What you want to see are aerograms and the bronchovascular marking in these areas. The third thing, if it is present, it is abnormal radiopacity. Definitely I have done much talk before on the radiopacity. Now, proportion of the aerogram with the bronchovascular marking here are normal. This is the hilar divisions and bronchovascular markings coming out to this one, this one, this one. On the left side is always present, always. On the left side you see no. This part there is slightly more aggregation of the bronchovascular markings. I don't know about the patient is a smoker or not. I don't know about it. To me it seems to be because it has got the middle zone involved and the hair middle zone involved also. It is I think it is smoker's chest. So there is no abnormality in the. Now try to see this one. First one this, then this, then this, then this. Compare the both intercostal spaces. Anything abnormal you find, there is no abnormality. The proportion of aerograms and the bronchovascular marking are normal. Always remember this is not abnormal, this is normal because left lower lobe is more vascular than anything else. It works maximally. It needs more blood than. That means lung fields are normal. Anyway, the dome of the diaphragm, curved one, 2.5 centimeter between the upper dome. So upper dome is higher. Costophrenic angles are clear one. Cardiophrenic angles are clear one. No problem. So dome of the diaphragms are normal. Upper part and the lower part of the domes, they don't seem to be anything abnormality which is seen. Then go for the middle mediastinum, lower part of the middle mediastinum, upper part of the middle mediastinum. It is divided when the border, the left border and the right border, that changes its direction. Here it is changing direction, here it is changing direction. So this part should be underlined. imaginary. This is the lower part, which indicates the heart and the coverings. Upper part, the great vessels. The lower part, the two things should be noted: size and the shape. The size, the maximum ratio or maximum diameter of the chest cavity should be taken above the dome of the diaphragm, here to here. So I measured it, and it comes to me. After measurement, I measured it. It comes to me like, for example, it is 18 centimeter, 20 centimeter, 20 centimeter. Then I measured the maximum breadth of the cardiac shadow here to here. This is the maximum one. This one. It seems to be here is about 11 centimeter. So because half of 20 is 10, it is 11 centimeter, it means that there is cardiomegaly in this patient. If it is deeply inspired and hold the breath properly, all things are there. Thing is this, because the patient has kyphoscoliotic, so this marker is lost. You cannot comment on the cardiomegaly because of these kyphoscoliosis. Many changes seen in the X-ray and the ECG and the clinical examination of this patient, which are variable, normal to the kyphoscoliosis. The shape is that the right border is here, the right border, the upper part, 1/3, indicating the superior vena cava, the middle 2/3, indicating the right atrium, and the lower 1/3, indicating the inferior vena cava. This is the border. The left border is divided into two, upper 1/3 here, denoting the left atrium, and lower 2/3, indicating the left ventricle. The right ventricle is here somewhere. It is not seen here. Indirectly, you can say if right ventricle is large, then it pushes it on the right side, this border. Indirectly, you can say it is right. Otherwise, it is not directly, because no right ventricle is visible here. Left ventricle is visible here, yes. And there is upper part of it means that this is the cardiomegaly, but according to the kyphoscoliotic variable, it is normal. But another important point is here, the upper part of the middle mediastinum will be divided into 4 imaginary line. This one. This is the first, second, third, and fourth. The first indicating the ascending aorta, second plus third will indicate the arch of aorta, this is aortic knuckle, and the fourth one here, the bump which is seen here, is the pulmonary conus. This is the pulmonary main trunk of the pulmonary artery. It is visible and a prominent one. Now, the patient is developing the pulmonary hypertension accordingly. After it should be, it should be diagnosed rather or confirmed by the echocardiography. What is the pressure here? Because the kyphoscoliosis will definitely cause burden on the right ventricle also. So other studies should be needed. But what is seen in the X-ray, you should report it. Right hilar here is a big one. Because the bronchovascular marking, the main trunk is this, the upper part is this, the lower part is this. The shape and the size are normal. The left hilar is C-shaped inverted. It is within a normal range. The side calcifications are seen in these hilar, otherwise normal. The hilar is described separately, right hilar and the left hilar, always remember. Then afterwards, you have done all these routine protocol. The conclusion is that this patient has been suffering from the bony deformity. Because of the bony deformity, we cannot comment on the trachea, we cannot comment on the cardiac size, rather the pulmonary conus is visible, prominent, and these are the positive findings. It means conclusion means positive findings. The inference is this: our conclusion is this, our inference is this. Then referral or other investigations, oblique, yes, we will do the lateral view, we will do the echocardiography of this patient, electrocardiography as well as echocardiogram. See specifically the spine, kyphoscoliotic spine. I'll say, I'll repeat it, it will change the X-ray, normal skygram to abnormal. It will change the ECG to abnormal, although normally the patient is normal. And in this fashion, the echo is also disturbed. Its normal profile is changed. Even clinical examination will reveal abnormalities. Added sounds, for example, short systolic murmurs and other things. The patient has come to us because of the removal of the part of the foot. Surgical resection is needed there. Now, I have reported like this, advising that the random blood sugar, A1C, the urea creatinine electrolyte should be normal before going to surgery. And he should be evaluated for these abnormal presentation in the skygram. So this is how we report this skygram with some of the parameters of the routine investigations. This is the correct form, how you write it down, on the how you report it. This is the way to report it, which I have done. I hope that you have actually revised the previous session 1 to 9 and then report it on the piece of the paper in a black and white, and discuss it yourself that these are the abnormalities and it should be investigated further. Inshallah, we will meet again in the next skygram, plain skygram chest with some clinical profile and some of the investigation adding. So the case discussion is going on with under the umbrella of this X-ray chest plain peer view. Inshallah ta'ala, afterwards I will inshallah talk about the next X-ray. Subhana rabbika rabbil izzati amma yasifun wa salamun alal mursalin walhamdulillahi rabbil alamin. Assalamu alaikum wa rahmatullahi wa barakatuh.